Hello everyone, let us discuss about part 5 of antiarrhythmic drugs, and in the current session we will be focusing on drugs used for PSVT, sinus cardia and AV block. Coming to paroxysmal supraventricular tachycardia, it is a sudden onset episodes of atrial tachycardia and the rate of PSVT is 150 to 200 beats per minute and 1:1 ratio atrioventricular conduction is seen. It occurs mostly due to circus movement type of re-entry occurring within or around the AV node. It can also occur due to functional re-entry between atria and ventricles, as in case of Wolff-Parkinson's-White syndrome. Now, an attack of PSVT can be terminated by reflex vagal stimulation through Valsalva maneuver or by splashing ice cold water on the face or by hyperflexion, which is nothing but placing our head between the knees. If the attack does not subdue by the above, the clinically used drug of choice is adenosine. IV injections of verapamil, diltiazem and esmolol are also employed as alternatives, but the drug of choice is adenosine. And the oral therapy with verapamil, diltiazem or propranolol alone or combined with digoxin may be given to prevent the recurrent attacks of PSVT. Now, coming to adenosine. Adenosine is an ultra short acting endogenous purine signal molecule, and more than 90% of the episodes of PSVT are terminated within 30 seconds by administration of adenosine. It is administered as a free base or as adenosine triphosphate. It is an important chemical mediator with effects on breathing, cardiac and smooth muscle, vagal efferent nerves, platelets and cardiac conduction system. Now coming to the mechanism of action of adenosine. Adenosine activates acetylcholine sensitive potassium channels to increase the inward rectifier K plus current or the potassium current, and this causes the membrane hyperpolarization through interaction with A1 adenosine receptors, which are G protein coupled receptors on the SA node fibers, AV node fibers and in atrium. And the adenosine indirectly reduces the calcium current in the AV node. And finally, depression of the reentrant circuit through AV node is the reason for termination of majority of PSVTs. Coming to the kinetics, it has short T-half in the blood. Adenosine has a short T-half in the blood, that is around 10 seconds, due to uptake by RBCs and endothelial cells, where it is converted into 5-AMP and inosine. As a result, the effects of IV bolus dose of adenosine lasts only for 10 to 30 seconds. Now coming to the drug interactions. Drugs such as theophylline and other xanthines, they block the adenosine receptors and inhibit the actions of IV adenosine. For that reason, high doses are required in heavy coffee and tea drinkers. The next drug interaction is with dipyridamole, which is a vasodilator and antiplatelet drug. It blocks the uptake mechanism of adenosine, potentiating its adverse effects. Now coming to the benefits of adenosine for PSVT. When compared with verapamil, efficacy is equivalent to or better than verapamil, and the adenosine action lasts for less than 1 minute, and the adverse drug reactions, even cardiac arrest, if they occur only for some time, that they are transient. And adenosine is beneficial in situations where verapamil is contraindicated. Like it can be given to patients with hypotension, congestive heart failure and those receiving beta blockers, because adenosine has no hemodynamic deterioratory effect. It is safe in wide QRS tachycardia, and it is also effective in patients who are not responding to verapamil. These are some of the benefits of adenosine in treating paroxysmal supraventricular tachycardia. Now coming to the side effects. Shortness of breath, chest pain, fall in BP, dizziness and flushing are some of the side effects. Coming to contraindications, adenosine is contraindicated in asthmatics because the bronchospasm may be precipitated. In such cases, verapamil is the drug of choice. And additionally, patients on carbamazepine are at greater risk of developing heart block when adenosine is given. Now coming to the other uses of adenosine. In addition to treat PSVT, adenosine is also used diagnostically for some purpose. It is used for the diagnosis of tachycardias which are dependent on AV node. And it is also used to induce brief coronary vasodilation during certain diagnostic and interventional procedures. It is used to produce controlled hypotension during the surgery. And one more important point is regadenoson is an adenosine receptor agonist. Adenosine 2A, the subtype is 2A receptor agonist. It is used diagnostically in pharmacological stress testing. Coming to the next condition, sinus tachycardia. Inappropriate sinus tachycardia is an uncommon disorder and it includes symptoms such as palpitations, dysopnea, anxiety, dizziness, postural hypotension and it even precipitates angina. It can even precipitate angina. So in order to treat sinus tachycardia, verapamil and beta blockers are the drug of choice. In addition to that, Ivabradine is an anti-anginal drug and it is a pure bradycardiac drug. It lowers the heart rate and it is used as a second line drug to treat inappropriate sinus tachycardia. Now coming to next condition, that is AV block. Atrioventricular block is due to depression of impulse conduction through AV node and bundle of His, mostly due to the vagal influence or ischemia. AV block is due to depression of impulse conduction through the AV node and bundle of His, mostly due to vagal influence or ischemia. AV block is of three types: first degree, second degree and third degree. In case of first degree AV block, slowed conduction is seen and it leads to prolonged PR interval. When it comes to second degree AV block, some supraventricular complexes are not conducted and you can notice drop beats. Drop beats is the characteristic feature of second degree AV block. Now coming to third degree AV block, there is no conduction of supraventricular complexes. And here the ventricles generate their own impulses. And this is considered as complete heart block. Third degree heart block is considered as complete heart block. Now coming to the drugs for AV block. The definitive treatment of persistent heart block is pacing with an implanted cardiac pacemaker. The definitive treatment of persistent heart block is pacing with an implanted cardiac pacemaker. The drugs are of value only for acute and transient AV block and as an intermittent use. Coming to the drugs, atropine. When the AV block is due to vagal overactivity, for example digitalis toxicities and some cases of myocardial infarction. In such case, atropine is the drug of choice. The atropine abbreviates the AV node effective refractive period and it increases the conduction velocity in bundle of His. The AV block can be improved by administering 0.6 to 1.2 mg intramuscular injection of atropine. Coming to the next drugs for AV block, they are sympathomimetics, adrenaline and isoprenaline. They overcome the partial heart block by facilitating AV conduction and shortening the effective refractive period of the conduction tissue. And they may also be used in complete heart block, that is nothing but third degree heart block, to maintain a sufficient idioventricular rate. That is, by increasing the automaticity of ventricular pacemakers till an external pacemaker can be implanted. So the drugs used for AV block are atropine and sympathomimetics like adrenaline and isoprenaline. Thank you for watching. Please subscribe for further videos on pharmacology and other related pharmaceutical sciences.